Okie dokie, continuation of cardiac. I just want to make an announcement. If you were interested in purchasing the Ccrn video or the audio tapes, and we don't have any more, I don't know if we have any more, but I think we're running out or whatever, and you wanted them, you could order it through me. I'll go home and I'll go to the office, I'll mail it out to you, because I think it's $50 cheaper here or something like that, so you don't have to go pay the full price. So after, right before lunch, you know, when we break, come talk to me, and then I'll give you a piece of paper and you write your name and everything, and then I'll send it out to you, all right? Okay, cardiac trauma. Always one question on cardiac trauma. The most common valve rupture is the aortic valve. And what you have to know about cardiac trauma, you can have one or two things. When you have cardiac trauma, you can either have what's called a myocardial contusion, or you can have what's called pericarditis. Now, there is some differences. When you have a myocardial contusion, you only get ST elevation in those leads looking at the boo-boo, whereas when you have pericarditis, you get ST elevation in all your leads. So that's one difference. Another difference is it is far worse to have a myocardial contusion than it is to have pericarditis. It's worse to have a myocardial contusion. A myocardial contusion is far more than just a black and blue or a bruise of the heart. A myocardial contusion, you have contused the heart, but you have broken some blood vessels that wind up bleeding into the heart muscle, which makes like a black and blue. But that blood and that blood vessel was on its way somewhere and didn't get there. So you wind up having dead tissue when you have a myocardial contusion. It's sort of like having a myocardial infarction. So if you have a choice to come in with cardiac trauma, you'd rather come in with pericarditis than a myocardial contusion. You know, this is, you know, serious, and you really got to keep your eye on these people because they run the risk of cardiac arrhythmias and death within the first 48 hours. You do run the risk of getting cardiac tamponade when you have pericarditis, but you know, if you have a choice, I'd rather get pericarditis than a myocardial contusion. Now, both of these conditions give you ST elevations. Again, pericarditis, ST elevation in all your leads. When you have myocardial contusion, ST elevation in those leads looking at the boo-boo. There is a difference, though, in the ST elevation. Even though it's elevated, a myocardial contusion gives you sort of like a sad face, whereas when you have pericarditis, you get more like a happy face, like, oh, I just have a little pericarditis. Oh, shoot, I got me a myocardial contusion. So it's, you know, far worse of a myocardial contusion than it is to have pericarditis. So this is bad. Not that bad. But you got to watch out for cardiac tamponade. You know, cardiac tamponade would be muffled heart sounds, right? Neck vein distension. What else do you get? Narrowing pulse pressure. So keep your eye on that. My mother-in-law had a pacemaker put in. And on the way to the hospital, my husband's like, now, Laura, when we go to take mother to put the pacemaker in the hospital, can you keep your mouth closed, all right? Don't go annoying people, because if you wind up annoying people in the hospital, they're going to take it out on my mother. I'm like, don't worry about it. So anyway, we get to the hospital and in the cardiac cath, the waiting room or whatever, and we, you know, kiss her, good luck. And then we're waiting 1 hour, 2 hours, 3 hours. I'm like, Charles, it don't take 3 hours to put a pacer in. There's something going on in there. I really need to go in there. It's like, Laura, don't annoy people. They'll take it out on my mother. I'm like, So anyway, the nurse finally, after like 3.5 hours, pops her head out and says, you know, you can come in, but just for a minute, your mom doesn't feel well. So I'm like, see, I told you I should have been in there. So anyway, we go in there, and as soon as we go into a little, you know, she's in a stall there. As soon as I go in there, I look at her, I know something's wrong. You know, you could just tell something's wrong. I don't like her color, I don't like nothing. Now, she always had a heart rate of 30, and then all of a sudden they decided to put a pacer in. She was fine. But anyway, they put a pacemaker in. I look up, and her heart rate's 130. She's tacking away like crazy. I said, Charles, it's 130. He's like, Laura, they just put a pacer in. I'm like, oh, stop it. right, so then I'm like, I tell you, my mother-in-law, what's the matter? Tell me everything. What's the matter? What's the matter? You have pain? What's the matter? So she tells me she has horrible pain over here. I'm like, oh my God. So I'm working the bed. I'm lying her flat, sitting her up. Anyway, when she's lying flat, ooh, it's horrible. Whereas when I sit her up and make her take the pillow and make her hang out like this, it's a little bit better. So I'm like, So then I say to the nurse, you know, what happened? How come it took like 3.5 hours to put a pacer in? She says, oh, well, we put it in, we took it out, put it in, it fell on the floor, put a new one in, you know. Went through the right ventricle, went out, came in, you know, blah, blah, blah. I'm like, hello, okay. So then they call the cardiologist, who then, you know, checks out my mother-in-law because she has this pain. They do an EKG, and on the EKG, I noticed that in leads 1 and in AVL, the lateral wall leads, you're supposed to be, you know, looking like that. But instead, I noticed my mother-in-law in 1 and AVL has inverted T waves. And she never used to have that. Now, if you never had inverted T waves in 1 and in AVL, and all of a sudden have them, it means that your left ventricle is working really hard. So I'm saying to myself, why should her left ventricle be working really hard? Sometimes if you're having a hypertensive crisis, or if you're hypertensive. But she wasn't hypertensive. She usually is hypertensive, but she wasn't then. Her blood pressure was like 90/60, so that was another clue. So then I'm saying, why is her left ventricle working really hard to squeeze the blood out? So then the physician, the cardiologist says to the nurse taking care of her, you know, give her a nitro and see what happens. And then he leaves. So I say to the nurse, I said, you're not going to give nitro, are you? So she said, well, that's what he ordered. So I'm trying to explain to her that she shouldn't do it, that I don't even think that he didn't even say nitro. He said echo. That's what he said. He said echo. I heard him say echo. Then my husband's like, Laura, Laura. I'm like, stop. So anyway, we have this big marital spat, you know. So anyway, I say to the nurse, listen, I really wouldn't give her the nitro, okay? Call another doctor, do whatever you want, make like you didn't hear him, you know? Okay. So anyway, she says, well, no, I have to do what he says. I'm like, oh, please. So I said, you better not. She's going to die if you give it to her, okay? I don't want to scare you or anything. But anyway, so my husband's like, Laura, Laura, I get a little too dramatic. So he's like dragging me out. I'm like, you know, leave me alone. I'll beat you up right here. All right. So then the nurse gives my mother-in-law nitro. And then my husband's like, Laura, can we leave now? I'm like, this is not the time to leave, okay? All right? Anyway, so I have another marital spat. So then he's walking away, and then my mother takes the nitro under her tongue and everything, and then the nurse leaves, and then all of a sudden my mother-in-law, her eyeballs went behind her head, and then I look at the monitor, the alarm didn't go off, but all she had was a bunch of P waves with spikes, you know. The alarm didn't go off because it was picking up the spikes as a yeah, it's like, hello, don't you have a pacer button on the app? All right, but that's another story. So then, you know, then I look at her eyeballs go behind her head. I'm like, Charles, you want to come over here? Your mother's dead now, okay? All right. So then, so we have this big marrow spat. Anyway, we bring her back to life, blah, blah, blah. When they brought her to the OR, they drained 550 cc's of blood from around her heart. She had a cardiac tamponade. So anyway, you need a nurse to save your life. Okay, so now at any family functions, you know, everyone's like, oh, Rose, you look so good. You look so good. And she's like, oh, my son, he's a doctor. So then I kick my husband on the table like this. He's like, Ma, Laura helped too. Help. Saved your life. Anyway, so cardiac tamponade, you do gotta watch out for that. You don't get any, no one pats you on the back as a nurse. I tell you, every day you got to pat yourself. Every day you got to pat yourself. I want to tell you, you'd be pushing up daisies if it wasn't for me. All right, pericarditis. ST elevations in all your leads, right? We said that. Other things you need to know, you get the happy face. If you do have pericarditis and it's not from cardiac trauma, it could be a viral condition or MI or post-op radiation, or maybe it just occurs and they don't know why. People get pericarditis after an MI. It's known as Dressler's syndrome, right? And it's a sharp stabbing pain, increases with respirations. They get a low-grade fever, little dyspnea, a little cough. After an MI, you get Dressler's. And the chest pain is relieved by sitting up and leaning forward. And again, you're going to watch out for cardiac tamponade, hypotension, elevated neck vein distension, and pulsus paradoxus. That's another thing. Pulsus paradoxus. Pulsus paradoxus is explained in every nursing book very incorrect. Pulsus paradoxus, I think the nursing books explain it that it's a drop in mercury by 10 millimeters or more when people are taking a deep breath in. that's wrong. I mean, if your mercury is bouncing when your patient's breathing in, it means that there's a leak in the cuff. That's what that means. What pulsus paradoxus is the absence of bumps during inspiration. That's what pulsus paradoxus is. It's the absence of bumps during inspiration. You know, when you take a blood pressure, you let the air out. When you're letting the air out, you hear what? Bumps. Boom, boom, boom. I think they're called Korsakoff sounds. But anyway, you hear bumps. Boom, 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 boom. You'll notice that whenever the patient takes a deep breath in, you don't hear a bump. Boom, 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 boom. Boom, 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 boom. It's the absence of bumps during inspiration. And they don't use that 10 millimeters of mercury anymore business because it all depends on how fast you take a blood pressure. I mean, if you're a real speed demon with the blood pressure, you pump it up, and then you let the air out. Well, you could let all the air out, and the patient didn't even take a breath yet. So it's the absence of bumps during inspiration. That's what pulsus paradoxus is. Always one question on the test about pacemakers. Always one question about pacemakers. They'll give you a strip, and it'll either be a situation where the pacemaker is not capturing, right, failure to capture. Maybe the lead is dislodged or battery failure, faulty connections. You know, another thing that makes pacemakers not work too good, you know, patients are in beds, and the beds are plugged into the wall. And they're three-pronged beds. And I noticed one time in this one hospital, I used to notice that anybody in bed 5 with a pacemaker would always die. Couldn't figure out why. I thought it was, you know, they used to say, oh, we're transferring Mr. So-and-so, he's a pacer, putting him in bed 5. I'm like, oi! And then, you know what I found? The bed, you know that third prong was broke off. So the bed was not grounded, and people would take the pacer and tie it around sometimes you don't clip it on them, you put it on the bed railing or frame or whatever, and it would just short circuit something or other. So that's a horrible thing. Anyway, in this situation here, you'll notice spikes on the T wave, so this is failure to sense. All right. So on the exam, it's either failure to capture or failure to sense. So no problem. You're not going to have any problem with the pacemaker question on the exam. Now let's do a little bit of shock. A lot of questions on shock. Primarily septic shock. That's what they tend to focus on. Now if you look at your core curriculum, and then looking at the core curriculum, they have all different kinds of diagrams. Like this is one kind of shock in your core curriculum. Look, there's another one. Look, this is a septic shock. You're like, hello, hello. So anyway, I'm going to simplify all this. I'm simplifying all this mess here. Let's just give you an overview of shock. And in your core curriculum, it's about 14 pages. So I'm going to give you a nice overview of shock. You know, when people are in shock, no matter what kind of shock they're in, whether they're in cardiogenic shock, septic shock, hemorrhagic shock, hypovolemic shock, anaphylactic shock, neurogenic shock, no matter what kind of shock people are in, initially they'll go into the compensatory stage. After that, they go into the progressive stage. And then after that, they go into what's called the refractory stage. I don't talk about the refractory stage because to be in the refractory stage of shock means no matter what I do for you, you are not going to get better. So why talk about it? So that's why I'm just going to concentrate on the compensatory stage and the progressive stage, all right? The progressive stage of shock, or the compensatory stage of shock. What this means is this. You have a decrease in cardiac output. Maybe you're in septic shock. When you're in septic shock, you vasodilate your capillary beds and you pool 50% of your circulating blood volume in your capillary beds, thus decreasing your cardiac output. Or maybe you're in anaphylactic shock, whereby there's histamine release, which vasodilates your blood vessels. You pool your blood in your capillary beds, thus you have a decrease in cardiac output. Or maybe you're in cardiogenic shock, where you have an anterior wall, you infarcted your left ventricle, and your cardiac output goes down and because of a failing left ventricle, or maybe you have hemorrhagic shock where you lost your blood, thus giving you a decrease in cardiac output. Whatever the reason is, whenever you have a decrease in cardiac output, your sympathetic nervous system will become stimulated. And that's because you have baroreceptors in the carotid and aortic arch. And these baroreceptors sense the tension in the blood vessel. And whenever your carotid and aortic arches, the baroreceptors in those blood vessels, sense that there's a decrease in pressure, they will stimulate your sympathetic nervous system to release adrenaline. And adrenaline will increase your heart rate and vasoconstrict your blood vessels and cause your kidneys to hold on to water. It would release ADH, your brain, and hold on to water. So whenever you're in the compensatory stage, it's the body's way of making you look pretty good, in that the decrease in cardiac output stimulates the sympathetic nervous system, adrenaline is released, so you have an increase in cardiac output, increase in blood pressure, increase in ADH release, and vasoconstriction. Now, this is a reason why you don't want to put people in Trendelenburg. Trendelenburg should not be used. People still use it. It used to be they thought your abdominal contents, push up against your diaphragm, you decrease your tidal volume. You don't want to put people in Trendelenburg because you pool blood in the carotid and aortic arches. And by pooling extra blood into your carotid and aortic arches, you stretch those blood vessels and you make the baroreceptors think there's not a problem going on. Therefore, you don't have any adrenaline release, you won't get the tachycardia, you won't get the kidneys holding on to water, and you're not going to do well. So you don't put people in Trendelenburg, although in SICU they got everybody on their head. You walk in there, all patients are, their whites of their eyeballs are all swollen, they can't close their eyes. These poor people on their head 24 hours a day, I don't get it. Then you go up there and you try to tell some of the fellows, or whatever they call them, surgical practice doctors or whatever. You say, listen, you shouldn't put the guy in Trendelenburg. You put my patient in Trendelenburg. I'm like, you don't want to do it, all right? If he has a low blood pressure, don't worry about it. We're giving him normal saline, we give him fluids, blah, blah, blah. Put patient Trendelenburg. I'm like, it's not going to happen. So then all of a sudden he puts the guy in Trendelenburg. I'm like, it's not happening. We're like 5 poor guys, up, down, up, down. Then I said, listen, come outside, I have to talk to you. So I go outside and say, listen, you don't want to put the guy in Trendelenburg, all right? And I explained to this intern, whatever he was, that whenever you do that, by putting the patient in Trendelenburg, you pool blood in the carotid and aortic arches, you fool the baroreceptors, I'm using like big words and everything, Anyway, it went over his head. So I figured, let me do like a Sesame Street approach. So then I'm doing like a Sesame Street approach. I'm saying, Mr. and Mrs. Baroreceptor live in the carotid and aortic arches. I'm doing like this, right? Over his head again. Because then he says to me, Mr. and Mrs. Baroreceptor, where are these people? Where are they? They're in the waiting room. They went to the cafeteria, right? Get out of here. So then I tell him, then he comes in and then we're having another argument. He wants to give the guy has a blood pressure of 60 pounds. He's awake, but it's not a good blood pressure to have. He wants me to hang low-dose dopamine on the guy. I'm like, it's another bad order, all right? I'm not doing it, not today. I'll do it tomorrow, but not today, all right? You hang low-dose dopamine. You hang the low-dose dopamine. I'm like, I'm not going to do that. Low-dose dopamine vasodilates your renal mesenteric arteries. And so what you do is you wind up pooling about 7% of your blood volume in your kidney. I'm trying to explain to him, maybe in your country, all that people need is a good urinary perfusion. But here, you need cerebral perfusion. I'm not hanging, all right? Then I wind up calling the attending. I'm like, listen, it's a teaching hospital. Ain't nobody here teaching anybody anything. And he says, put him on the phone. So I put him on the phone, and then he says, when those nurses say jump, you jump! They've been here longer than you. They know what they're doing, When they say get down on your knees, you get down on your knees, And I'm like, then when he hangs up, I said, so what did he say? He said, oh, not to give dopamine. I'm like, oh, he said more than that. But anyway, so the compensatory stage is something your body puts itself into in order for you to start looking good and feeling better, okay? But you can only be in the compensatory stage for a certain amount of time. I mean, you can only vasoconstrict your blood vessels for a certain amount of time. Because if you vasoconstrict the blood vessels in your muscle too long, you build up in lactic acid. Once you start building up lactic acid, you'll go into a state of acidosis. Once you're in the state of acidosis, you vasodilate your blood pressure, and bada boom, you become hypotensive. You're now in the progressive stage of shock. And you hate when people are in the progressive stage of shock, because once you go into hypotension, then we're talking about ARDS, we're talking about DIC, you're talking about multi-system organ failure. That's why you need a nurse to save your life, because there's going to be a nurse to spot the signs of the compensatory stage of shock. Now, all the books say when people in the compensatory stage of shock, they're anxious and irritable. And when they're in the progressive stage, they're stuporous and obtunded, which are stupid signs to look for. These are dumb signs to look for. Anxious, irritable, stuporous, obtunded. Hey, everybody's in the hospital. Half the people in the hospital, both staff and patients, are pretty much cranky and irritable, and the other half are pretty much obtunded and stuporous. So these are stupid signs. That's why the best sign to look for is narrowing pulse pressure. Narrowing pulse pressure, orthostatic blood pressure changes. Very important, which is really sad because in a critical care environment, everyone's in a semi-Fowler's, a low Fowler's. Everyone's in a low Fowler's. You know, heaven forbid you put them in any other position. So you should put them in other positions to look for orthostatic changes. And again, anxious and irritable for the compensatory stage, obtunded and stuporous. Dumb signs to look for. Again, everybody anxious and irritable. Well, half people anxious and irritable, the other half obtunded and stuporous. Some of the signs in compensatory stage: tachycardia, cold, pale, decreased urinary output, and then hypotension, decreased CVP, increased SVR, decreased wedge rather. And if someone's in hypovolemic shock, such as this shows you, then you need replacement volume, crystalloids, colloids, fresh frozen plasma, RBCs. Whenever you give any kind of colloids, if you give you ever give that 50 cc bottle of salt pore albumin, right? And whenever you hang it, it never drips, right? Never drips, right? You squeeze it, right? Still not dripping. Put it all the way up, still not dripping. Squeeze that little chamber again, the whole chamber fills up with bubbles. Then you can't even see if it's dripping. Then you gotta go like this and squeeze it back in. Then you put it up, and now there's all bubbles in the chamber. Now you really can't tell if it's dripping. So then you flick. Then you say to yourself, you know what, I'll get a needle. I'll vent it. So then you get a needle, you vent it. Really, you're not venting anything. Because in order to vent, the needle has to be in air, but it's never long enough, so it just hangs out. That's why some always drips on the floor. You ever notice? Just a little bit. Not a whole bunch of them. Just 1 or 2 little drops. You have to go like this, that's all. And then all of a sudden it starts dripping. And you think it's dripping because you put the needle in. Had nothing to do with it. Colloids, salt pore albumin, which is 25% albumin, takes 4 minutes to equilibrate. Takes 4 minutes to drip, which is the amount of time it takes you to go like this, put it over here, go get a needle, go put it in. All right? If you don't have time to wait, what you can do is, you know when you get the tubing? You have the tubing, right? Clamped off here. Take the chamber, squeeze it 10 times. Then keep it depressed, plug it into the bottle. Hang it up, run it through, and then whoo. So that's the best way of doing that. Cardiogenic shock. Now, who goes into cardiogenic shock? Well, usually people with myocardial infarction, although cardiomyopathies can do it, arrhythmias, cardiac tamponade and papillary muscle rupture. All these people can go into cardiogenic shock. When people are in cardiogenic shock, what you're going to see is confusion and restless and rapid respiration. They develop brails because of left-sided failure, very thready pulse. They get neck vein distension, narrowing pulse pressure. You'll hear an S3 and an S4, hypotensive, oliguria, decreased cardiac output, and an elevated CVP, SVR, and an elevated wedge pressure when they're in left-sided failure. Left-sided failure, cardiogenic shock. Treatment is early reperfusion if it's due to myocardial infarction or ischemic event, PCTA, thrombolytics, cabbage surgery, intra-aortic balloon pump, inotropic drugs. Now, there's always going to be a question on the exam about the intra-aortic balloon pump, and very often there's 2 questions about intra-aortic balloon pumps. If you don't work with them, don't be afraid. Really easy question, very, very easy question. You need to know that an intra-aortic balloon pump decreases afterload, decreases myocardial O2 demand, increases coronary perfusion, and improves cardiac output. So if I could explain to you, those that don't work with intra-aortic balloon pump, how it works, it's very, very simple. You got this catheter, and this catheter is threaded up through the femoral artery and hangs out in the aorta. It's this catheter. It looks like a Stinson Blakemore tube because it has a balloon on it. It has a balloon, and what happens is, as the catheter is in your aorta, the balloon will inflate, deflate, and of course the patient's chest should not be doing this because then maybe I'm thinking some kind of overinflation going on, but just to be dramatic, the balloon will inflate, deflate, inflate, deflate, inflate, deflate. Now common sense would dictate that you wouldn't want this balloon to inflate as the left ventricle is in systole. Because if the left ventricle is in systole, if that aortic valve opens up and all the blood in your left ventricle is going to go out into your aorta, it certainly don't want to be smished into a balloon. So common sense would dictate that you wouldn't want this balloon to inflate as you are leaving the left ventricle, because then you just hit the balloon and so then there goes your cardiac output. So common sense would dictate that you, during systole, would want the balloon to deflate. Right? You want the balloon to deflate. Because see, when the left ventricle is in systole and all the blood comes out of the aortic valve, you get pushed into your aorta that already has blood in it. So when the blood comes out of your left ventricle, right, you go through the aortic valve and you get pushed into a pipe, the aorta, that already has blood in it. Splat, splat, splat. Wouldn't it be fun if you were to come out of your left ventricle, right, aortic valve opens, right, you get squeezed out of your left ventricle and you get squeezed into a tube that don't have anything in it. Because it used to have a balloon, but the balloon deflated. And when the balloon deflated, it makes for an empty aorta. It also, when the balloon deflates, causes like a little vacuum. So you sort of like get sucked out of the left ventricle. It's clear sailing ahead. So that when the ventricle's deflating, the balloon's deflating, right? Ventricles deflating, balloons deflating. So when the ventricles are in systole, the balloon is deflated and it's clear sailing ahead. There's no resistance to left ventricular emptying. So it really decreases afterload, the amount of resistance met by the left ventricle during systole. It decreases afterload. It improves cardiac output. Then what happens is after your left ventricle empties all the blood out, then the aortic valve will close and your balloon will inflate. When the balloon inflates, it displaces the blood now. Some of the blood goes down towards your kidneys and some goes up into your coronary blood vessels. Your heart muscle receives the blood supply during diastole. So that if this balloon inflates when your heart's inflating, the balloon inflates when the heart's in diastole. So the balloon inflates during diastole, and that's when your heart muscle receives its blood supply. So this balloon inflating is going to displace the blood in your aorta into the blood vessels that are going to the heart muscle during diastole to give your heart more blood, more oxygen during diastole. So it really improves cardiac oxygenation. It improves cardiac output. It decreases afterload. Could you ask for more? So, and common sense would dictate you wouldn't want to have someone anterior balloon pump and sit them all the way up in bed, right? Because like a question on the test is, what position would your patient has an anterior balloon pump is going to eat breakfast, what position would you put him in? And I'm saying to myself, you know, I mean, again, it depends where you work. I mean, usually when we use intra-aortic balloon pumps, you're in real bed. You know, breath is like the last thing on your list. You know what I'm saying? But apparently, if you work in like big medical centers and university centers, blah, 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 people do eat on the intra-aortic balloon pump. And then you can't sit them up in the high phallus because you would kink this thing and maybe the balloon would stay inflated the whole time, and that would be a problem. So you got to keep them in the low phallus. But, and you always got to check all your pulses because sometimes the balloon rides up and blocks some arteries. So always check your pulses. And They ask you on the exam, contraindication to the intra-aortic balloon pump, and usually it's aortic insufficiency. If you have aortic insufficiency, which is an aortic valve that just don't close good, if your aortic valve doesn't close good, the last thing you need is a big balloon underneath it, inflating, displacing all the blood not into your coronary blood vessels, but up through the incompetent closed aortic valve into your left ventricle. So aortic insufficiency is a contraindication to the intra-aortic balloon pump. And then they want to know, when does the balloon inflate, when does the balloon deflate? And you would say the balloon will inflate when the heart's inflating, diastole, and the balloon will deflate when the heart's deflating, which is systole. Good. And the complications would be ischemia of your limb, dissection of aorta, infection. Don't elevate the bed too high, assess the pulses, monitor for bleeding, and remember that the balloon inflates during diastole. Balloon inflates when the heart's inflating, and the balloon will deflate during systole. The balloon will deflate when the heart's deflating. And that's all the information you need to know for those 2 questions that you'll see on the exam. Tell you, makes you want to go into work, doesn't it? No, eh? What'd you get for Nurse Week this year? You know, in the hospital I was working in this year, they put me in charge of Nurse Week because I have the biggest mouth, you know. They're like, hey, let's put Ccrn in charge of it. So, but it was their idea. They just put me in charge of it. Their idea, nurse administration's idea was to have everybody in the hospital. I have a house, I live in Staten Island, but I have a house, a log cabin upstate, you know, so we go there like every weekend. All right. So I work in a hospital up near Windham, Hunter Mountain, around that area. Anyway, so it's a small hospital, but I still have a big mountain bad attitude. But they really need staff, so they have to put up with me. Okay. And then no one ever wants to work Saturday night. Okay, so there's no choice. They're stuck with me. But so they put me in charge because I'm always complaining and stuff. And but it was their idea. Their idea was to ask everybody from the hospital, and it's a small hospital, to bring in a dish. You know, heaven forbid they spend $1 to feed you. Everyone has to bring in their favorite dish. And that nursing administration was going to taste it and judge, you know, the best entree, the best appetizer, the best, salad, right? So it was like a cooking contest. And nursing administration was going to judge it, okay? So another opportunity to seek administration's approval, you know? So I'm going around asking people what they're bringing in. And these nurses are going, well, I'll do the dessert category. I'll bring in like tea time tassies, and then somebody else is like, oh, I make a really good like vegetable lasagna, and I'm like, what are you, out of your mind? You ain't bringing that stuff in. I'll tell you what to bring in. I'm in charge of this thing. You're gonna bring in, what do you call those, Rocky Mountain oysters? You know, buffalo scrotal sacks. That's what it is, right? Right, what do they call it? Rocky Mountain oysters, I think, right? Or something like that. But anyway, it's buffalo scrotal sacks, all right? So I say, you bring in that, all right? Then you bring in like pig's feet. You bring in tripe. For those Italians, you know what tripe is, the inside of the cow's stomach. Maybe put a little tomato sauce, they'll never know. So we got tripe. We got the Limburger souffle. We had frog's legs. Oh, what else do we have? Oh, apparently it's some Japanese or Chinese or Japanese. I think Chinese. Uterus, pig uteruses. No, we had that, boiled pig uteruses. What else do we have? It was like the Fear Factor kind of a thing, you know? Oh, we had tongue, like a tongue, but you slice it so you really didn't know it was tongue, you know, and they rolled it up and made it with a little Swiss cheese or whatever. And so then I got like, close to 40 people bringing all disgusting things, and then that's what we brought in. And we put it out and everything, and I made little place cards, so of course they would know what they're eating. And then I'm like, so mangia, gistaka, come on, help yourself. How about a little pig uterus over here, you know? And they weren't happy, nurse administration. They were gagging, but I'm like, come on, taste up. How about this over here? A little tripe. Oh, here's another. We had sweetbreads. You know what that is? That's an Italian thing too. That's sheep's brain. Yeah, we had that. So I'm like, come on now, eat up, little sheep brain over here. If you're ever looking for a group of easily intimidated people, find some cluster of female RNs somewhere. No, really, they're afraid of their own shadow. Where'd you learn this, in nursing school? Yes. No, you didn't. It did. I did I did one of my dissertations. I did many. They kept on getting rejected, but like I don't know why you don't pick a nursing diagnosis. Why don't you do your dissertation and expound upon the nursing diagnosis? I'm like, it will be a cold day in you know where before I spend any time on that crap. Anyway, one of my dissertations that got rejected is I compared medical schools to nursing schools to try to understand the socialization of nurses, why they come out of nursing school and afraid of their own shadow. And so I sat in on 6 medical schools, right? 2 in the East, 2 in the Midwest, 2 in the West, and then I sat in on 6 nursing schools, 2 in the East, 2 in the Midwest, and 2 in the West. Very different. And sitting in on medical schools, as soon as you walk into the medical classroom, they shake your hand. They welcome you. Welcome, welcome, right? In 2 of the schools, they even called them doctors. They were first, not even an intern. They were like first year medical school. They called them doctor. Doctor, welcome, doctor. Right before your eyes, you saw the head go like this, boop. And then the classrooms are very different. Most of the classrooms are more like an amphitheater or a pit theater or whatever, where the teacher's down here and the students are all up there, and they're like, you will become physicians. Why, people will look up to you. They will hold you in the highest regard. And right before your eyes, you see the heads going, beep, 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 beep. So at the end of the week, they couldn't even get out the door. They had to open up both doors to get out. Then I sat in on nursing schools, right? Nursing schools. You got some cranky old bag sitting in the front of the classroom, right? Untouched by human hands, man and woman, haven't been in the hospital for about 40 years. Okay. Then all the nursing students are all coming in, everybody's all hot, happy, all good energy. Everyone's like, ah! Right? A lot of good energy. This old wench is staring you down. She's staring you down. How dare you speak in her classroom? She's staring you down. Finally, you get the message that maybe you shouldn't be talking, right? So then you'll be like, so everything's all quiet, and she gives you the eye, and she's like, look around you, because only half of you are going to be here, right? Like, so all of a sudden your head goes, I give care plans. I give care plans, and I never give an A, all right? They got to be 100 pages. I want them typed up in Kate Thurbian style, and I want 120 pages read by next Tuesday, and you'll get a quiz, and it'll be worth 30% of your grade, and no one ever gets an A, and maybe if you're lucky, you get a C, and right before your eyes, you know, the nursing students, by the end of the week, they're urinating on themselves in the hallway, you know? So that's where it all starts. Septic shock. Let's say a few words about septic shock. Septic shock. You know, septic shock is the leading cause of death in ICUs. Septic shock carries a mortality rate anywhere from 40 to 60%. Also, it's usually caused by gram-negative bacteria. Although it can be caused by gram-positive bacteria, it's usually gram-negative bacteria. And that could be either E. coli or Klebsiella or Pseudomonas or Enterobacter or Serratia marcescens. Whatever, it's usually caused by gram-negative bacteria, although you can get it from gram-positive bacteria. We're going to focus on gram-negative bacteria. Some of the predisposing factors of septic shock would be old age, granulocytopenia, severe burn injuries, alcohol, drug abuse. Although these people never die. Have you noticed people like this never die? They never die. Me or you, we come in with septic shock, we'll be dead in a week. If you're a drug addict, you'll live forever. I don't understand it. I just don't get it. You know, people get hit by cars, me or you across the street hit by a car, you know, we're dead. Yeah. Drug addict, alcoholic, live forever. Yeah, I don't know how this works. Recent surgical procedures, immunosuppressed people, and prolonged intensive care unit stay. Look, the liberals are giving me dirty looks, right? Take out more money out of your paycheck to feed these people, okay? All right, good. Now, gram-negative bacteria. Gram-negative bacteria may release an endotoxin. Sometimes it doesn't. But should it release an endotoxin, it starts the cascade towards septic shock. Because once the endotoxin is released, it causes your body to release vasoactive substances. It causes your body, and you don't have to know these words, to release cytokinins, bradykinins, interleukins, histamines, serotonins, tumor necrosis factor. You don't have to know those words. You just have to know vasoactive substances. And once those substances are released, it causes massive vasodilation, whereby you pool 50% of your blood in your capillary bed. Thus, you go into shock. Now, not all gram-negative bacteria releases an endotoxin. Let's say me or you are in the hospital. You're in one bed, I'm in the other. I say, hey, how you doing? Say, not too good. I got bacteria in my blood. I'm like, you're kidding. So do I. What kind you have? E. coli. I'm like, oh, me too. We have sepsis. We have sepsis. All of a sudden, at 12 midnight, I spike a temp 104. People around running around crazy, give me Tylenol, they put me on a cooling blanket, they draw my blood for cultures, blah, blah, blah. I have now entered into septic shock. You still have sepsis. You see, my E. coli released a gram-negative bacteria, E. coli, released an endotoxin. Yours didn't. They don't know why. Some do and some don't. But once you have released an endotoxin, it now starts the cascade to septic shock. Whenever you're in septic shock, you're in the warm stage and then you're in the cold stage, right? Initially you're in the warm stage and then you're in the cold stage. It's very important to spot when people are in the warm stage because the mortality rate is not that bad. Get people in the cold stage of septic shock, and the mortality rate is like 95%. That's why you need a nurse to save your life. You need a nurse to save your life because it's going to be that nurse to spot the signs of the warm stage of septic shock. Confusion. And you get confused because the endotoxins that release from gram-negative bacteria make you confused. Get an increase in cardiac output. A very good cardiac output, I might add. A lot of people think that you're working the cardiac output machine wrong. You're telling people, wow, I got a cardiac output of 12. They're like, she's doing it wrong. But no, your cardiac output is great when you're in septic shock. The endotoxin works on your heart muscle and makes your heart contract like it never contracted before. The endotoxin is 100 times stronger than digoxin. And the endotoxin has the ability to make even fibrotic heart muscle contract. I mean, you are perfusing body parts you never even knew you had. No, really. That's why people in the warm stage of septic shock, they look good. They look good, people in the warm stage. They look good. You ever give report on a patient? Oh, she's doing good. Oh no, she's doing great. Then you have off the next day. Then when you come in the day after that, you say, oh, how did Ms. Jones do? She get transferred to the floor? They're like, no, she died that day. I'm like, what? She was looking so good. People in the warm stage of septic shock, you look good. You have a glow. You're perfusing body parts you never knew you had. So you have an increase in cardiac output. You also have an increase in respiratory rate. The endotoxin works on your medulla and makes you breathe, have an increase in respiratory rate. And it's not one that you can really spot. It's not that they're hyperventilating, it's just a subtle increase in respiratory rate, which then gives them a very good ABG. Had a young guy who had a TURP. And what happened is in the middle of the TURP, they realized that they were using dirty utensils. No, not utensils. Instruments. Utensils. Hello. But anyway, no, well, if it's a dirty instrument, it's a utensil. So anyway, all right, so in the middle of surgery, they realized apparently when something's sterilized, it changes the dot on the thing. I forget how it goes. I don't know anything about it. But anyway, it was unsterilized. Okay, so now they're all nervous. Okay, so now what they do is they put them in MICU for us to keep an eye on them. And then what gets me is they have a lidocaine drip hanging, and there was no lidocaine in the drip. See, they wouldn't let the surgeon put the patient in the unit unless he had medical kind of a thing. So he said that he had an arrhythmia when he really didn't. He hung a bag, no lidocaine in the bag, you know, Can you imagine? Unbelievable. Me or you do this, we'd lose our license in a minute. And what gets me is the nurses are playing around with this drip that's not really a drip. They allow it. I don't get it. But anyway, so the guy comes in. He's alert and oriented. He's fine. He had a TRP. He's absolutely fine. I'm like, hi, how are you? How's your wife? How's your kids? How's your Foley bag? How are we doing over there? Everything's doing fine. Okay. So then, you know, I take his blood pressure and his pulse and everything, and I'm not going to take his respiratory rate. We're talking about his 2 kids in college. I'm going to say, oh, stop talking. I have to count your respiratory rate. You know, his eyes are open, and we're talking. I'm going to give him a 18 or something. Yeah. 16, 18. Yeah, I'll make something up. Don't worry about it. So I'm walking out of the room, and I'm just going to make up a respiratory rate. Then I said to myself, Laura, he's in here for you to watch him for septic shock. You really should count his respiratory rate. I'm like, oh. So then I got paranoid. So I went in there, and I said to him, I said, listen, I forgot what your pulse is. I have to take it again, all right? So I'm making like I'm taking his pulse, and I'm watching him breathe. I did for 15 seconds. I got 8. I'm walking out of the room, 8. 8 and 8 is 16, 16, 16, 32. I'm like, 32? We ain't breathing no 32 times a minute. So let me go back in the room. I said, hi, I just took your pulse. Yeah, I forgot. Let me take it again. So I take it again, and I take it for a whole minute, and I got like 34. I'm like, wow, just eyeballing it. You would never know he's breathing 34 times a minute. So I call up the attending. I said, listen, you know that guy that you put in the MICU under the guise of having an arrhythmia with the lidocaine bag with no lidocaine in it, that we're really supposed to watch him for septic shock? I said, he's starting to breathe. I got like 34 a minute. He said, all right, keep an eye on him. I'm like, all right, good. So then his wife came in to see him. And about an hour later, you know, I say to the wife, I said, he's doing good, right? She said, oh, he's a little off the wall. I'm like, what do you mean he's off the wall? She said, yeah, he's off the wall. And I said, like, off the wall, off the wall? She said, yeah, but, and I guess at my face, I looked concerned. She said, Dad, don't worry. My mother had surgery 2 weeks ago, and she got very confused from the anesthesia, too, so maybe it's a family thing. I'm like, yeah, maybe it is. So then I walk in the room, and the guy is off the wall. I mean, off the wall. So then I called up the surgeon. I'm like, hey, he's very, very confused now, and lo and behold, there he was in septic shock. So this increase in respiratory rate is nothing you can really eyeball. And because they have an increase in respiratory rate, they're really oxygenating. They have the best ABG you ever saw in your life. They have a great blood pressure because the endotoxin's working on the heart muscle. They have an increase in urinary output because in the warm stage, you vasodilate your capillary beds. And your kidneys are nothing but a mass of capillary beds. So if you're pooling your blood in your capillary beds, your Bowman's capsules are having a ball. They never filtered so much blood in their life. Therefore, you have the best urinary output. Now, all this all this in the warm stage, anyway, gets misdiagnosed. When the elderly come into the hospital in septic shock, and if they're coming into the hospital in septic shock in the warm stage, it's almost always missed. Because, see, when the elderly comes in, I'm down in the ER, I'm working with some GNs, and I get a report, some ladies come from a nursing home, fever, unknown origin. All right. So I say to this new nurse, listen, you're going to get a lady from a nursing home. She's like 89 years old, fever, unknown origin. And then she's like, like, excuse me? She's annoyed. She's annoyed because it's a patient from a nursing home and not one that the cops or firemen brought in, you know? And I tell you, in our ER, we have like nurse nymphettes, I call them. They're like little nymphettes. Really, we get a multiple trauma coming in. They're in the bathroom putting on lipstick. I'm like, hello? They're putting on lipstick. They're putting on lipstick. Did you ever? I don't remember being that boy crazy. Anyway, so you get this little old lady coming in, and she's confused. But what do you expect? She's a little old lady, you know? Then you take her blood pressure, it's like 150/90. You take her ABG, it's the best ABG you ever saw in your life. And this little nurse wants to know, why is she here? You know? And then you take the temperature, and it's down to 99. Right? And she's like, why is she here? Why is she here? Then she takes the Foley that's been in for 5 years, puts a new Foley in, and she got a great urinary output. She wants to know, why is she here? Now, why is the temperature down to 99? Well, what happens in the warm stage of septic shock is you vasodilate your blood vessels. And by vasodilating your capillary beds, you pool your blood, 50% of it, in your capillary beds. You bring your blood close up to the periphery, and you wind up cooling your own body down. That's why your temp comes down to 99. It's not coming down to 99 because you're doing better. It's because you're pooling your blood. And even though you only have 50% of blood volume in your circulating, you don't become symptomatic because your heart's beating like it never beat it before. And because your heart's beating like it never beat it before, even though half your blood's in your capillary bed, you do not become hypotensive because of the way that the endotoxins work on your heart muscle and make your heart beat like it never beat it before. But you need to know you can only be in the warm stage for anywhere from 30 minutes to 72 hours. After that, the endotoxins fizzle away. 30 minutes. The people that used to be in the warm stage for 30 minutes are, a long time ago, people used to come in with toxic shock syndrome. Remember anybody, an old nurse over here? Remember, I think it was back in the 70s, I want to say, right? 79, around there, 80s maybe? All these women were coming in with toxic shock syndrome, and right before your eyes, they would go from the warm stage to the cold stage, and almost all of them would die. Remember that? They were coming, oh, that was a horrible thing. I wonder what was behind that. I don't think it was tampons. They said it was the Rely tampons. No, I don't know about that. Some fishy going on there. But with that kind of septic shock, they were only in the warm stage for about 30 minutes. And because they were only in the warm stage for 30 minutes, you didn't have enough time to give them fluids. You see, when people are in the warm stage, you got to give them fluids. Of course, you're going to give them antibiotics. But what's really going to save their life is fluids. Fluids what's going to save their lives. Because once the endotoxins fizzle away and half your blood volume's in your capillary beds, I got to make sure you do not go hypotensive. Because should you go hypotensive, then you're going to get ARDS, acute tumor necrosis, multisystem organ failure. So I got to do everything to prevent you from going into the cold stage where you are hypotensive. So that's why in the warm stage, I got to flood you with fluids. If I'm able to flood you with fluids, then when you do go into the cold stage where you don't have any more endotoxins, you don't become hypotensive, therefore you won't die. But when people were in toxic shock syndrome, they were only in the warm stage for a half hour. So you didn't have enough time to flood them with fluids so that when they did go into the cold stage, they went hypotensive and they died. When you're in the cold stage, you're obtunded, stuporous, decreased cardiac output, decreased urinary output, very bad ABGs, you're in a metabolic acidosis, and the key thing here is you're hypotensive. And you hate that because you go into ARDS, you develop acute tumor necrosis, multisystem organ failure, DIC. That's why the treatment of septic shock is you must give fluids. You have to give a ton of fluids. And if you suspect that someone's in toxic shock syndrome, then when you give them fluids, you have to make sure that you have all the fluids on pressure bags and just get it in the body as soon as possible. In doing a shock chart here, and you have this in your book, so don't go looking at what the answers are. If someone's in shock, cardiogenic shock, right? If someone's in cardiogenic shock, left-sided cardiogenic shock, what's the preload? Increase, right? Preload's the amount of stretch on the myocardial tissue at the end of diastole, so it's increased. What's your afterload? Increase. Cardiac output, decrease. Hypovolemic shock, what's your preload? Decrease. What's your afterload? Increase. Afterload is the amount of resistance met by the left ventricle during systole. And if you are hypovolemic, your blood vessels will vasoconstrict. You are very vasoconstricted. So therefore, during systole, you are squeezing blood out into very vasoconstricted blood vessels, thus increasing your afterload, the amount of resistance met by the left ventricle during systole. And your cardiac output, of course, is going to be decreased. Then when you're in septic shock, warm stage, your preload is decreased. And the reason being is you pooled your blood in your capillary bed. Your afterload is decreased because, again, the vasoactive substances vasodilate your blood vessels. And your cardiac output is increased. Septic shock, cold. This is where you don't have any more endotoxins. So it's decreased your preload. Your afterload is increased now. Cardiac output decreased. Anaphylactic shock. Preload decrease, afterload decrease, cardiac output decrease. And the reason being is in anaphylactic shock, the histamines that is released causes massive vasodilation. This is written by Dr. Conga. Nursing is a very demanding profession. To start with, nurses must learn everything a doctor learns, so that whenever a situation arises that might develop into a mistake on the part of the doctor, if the nurse did what the doctor ordered instead of what he meant to do, the nurse can distinguish the latter from the former and prevent the mistake from occurring. Then nurses must learn how to use this knowledge so that neither the doctor nor the patient is aware that they possess it. For in the former instance, it can cause a patient lose confidence in the doctor, and in the latter, it may cause a doctor to lose confidence in himself or herself. Nurses are very patient people. They realize that their reward would not be in this lifetime. For to receive even a fraction of recognition they deserve would be to lessen the importance of a doctor. Nurses believe in reincarnation. Written by Dr. Conga. All right, just a quick overview. Asystole. If someone has asystole, you've got to remember TEA. TEA. They need transcutaneous pacing, epi, and atropine. 1 milligram epi, 1 milligram atropine. So if someone's flatline, transcutaneous pacing, epi, atropine. Got to remember the word T. TEA. If someone's bradycardic, you got to remember all trained dogs eat IAMS. IAMS is like a dog food. So all trained dogs eat IAMS. In other words, if someone's bradycardic, atropine is given, transcutaneous pacing, then you have some choices here, dopamine, epi, or isoproterenol. So it's atropine, all, transcutaneous pacing, trained, dopamine, dogs, eat, epi, IAMS, isoprel. So it's atropine, transcutaneous pacing, dopamine, epi, isoprel. You have a choice here. That's easy. Oh, look, all trained dogs eat IAMS. Atropine, transcutaneous pacing, dopamine, epi, and isoprel. That's easy. That's for bradycardia. Just a few questions here. A patient with a heart rate of 45 complains of dizziness, cool, clammy extremities. Where's the first drug of choice that you would administer? Atropine. And the reason why is he's symptomatic. He's cold and clammy, right? Cold and clammy, that's why you're going to give him atropine. Excuse me. You're treating a patient with a slow heartbeat. Which of the following patients would atropine be effective? Which would it be effective? Yeah, do it again. To give a 55-year-old man with severe chest pain and sinus bradycardia of 35, it tells you he's having a massive MI. You really got to take care of the MI first. You know, morphine, oxygen, blah, blah, blah. The best patient here would be the 55-year-old male with weakness and acute symptoms of nausea and vomiting with a sinus of 35. See, it's a severe chest pain that you want to shy away from the atropine. Third-degree heart block, atropine wouldn't work. And a heart transplant, atropine does not work because the vagus nerve is cut. So the answer would be the guy who's weak and nausea and vomiting. When you look at the PEA, pulsus electrical activity, you got to review the 5 H's and the 5 T's. You know, you have to say if someone's having pulseless electrical activity, are they hypovolemic? Are they having hypoxia? Any kind of hydrogen ion excess? Are they hypothermic or hyperkalemic? Or the T's, they have a tension pneumothorax, they have any kind of thrombosis, tamponade, tablet, toxin overdose. Usually the most common causes would be hypovolemia, especially in a trauma patient when they have you're taking care of someone, multiple trauma, and he's got an excellent EKG, but you don't feel any pulses. It's almost always hypovolemia. And then another thing could be is tamponade or tension pneumothorax. But anyway, when someone is in pulseless electrical activity, PEA, you got to think PEA. You got to think problem, epi, atropine. PEA, problem, epi, atropine. So that's easy. When you think of someone in VFib or pulseless VTAC, you know that you have a choice of you're going to defibrillate 3 times. Then you have either epi you can give or vasopressin, and then you defibrillate. Then you have a choice between amiodarone, lidocaine, magnesium, procainamide, and then you have to defibrillate again. So the easy way of memorizing this is please shock, shock, shock everybody, and E is for epi and V is for vasopressin. So it's please shock, 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 everybody shock, and let's make patients amiodarone, lidocaine, right? Magnesium, procainamide, dance for defibrillate, and then B, better for buffers such as bicarb. So it's please shock, 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 everybody shock, and let's make patients dance better. So again, you have a choice here after defibrillating over here of giving amiodarone, lidocaine, magnesium, or procainamide. Which of the following therapies is most important intervention for VFib, pulsus, VTAC, with the greatest effect on survival to hospital? The most important thing is defibrillation. Most important thing with pulsus, VTAC, or VFib is defibrillation. When you look at people in paroxysmal supraventricular tachycardia, you'll see that now vagal stimulation and then adenosine. And then they like to break it down with people with good hearts and people with bad hearts. If you have a good heart, right, if you have a good heart, we can give you just about anything. We can give you beta blockers, calcium channel blockers, digoxin, amiodarone. We can give you just about anything in the medicine cabinet. If you're talking about someone with a reduced ejection fraction, then I might have to cardiovert you, or I give you amiodarone, digoxin, or diltiazem. You see that if you have a bad heart, the thing I want to point out is if you have a bad heart, I cannot give you beta blockers and most of the calcium channel blockers. Right? The only calcium channel blocker I might be able to give you is diltiazem, but I can't give you any others because beta blockers and calcium channel blockers decrease myocardial contractility and would make your heart performance even worse. When someone's in wide complex tachycardia and you don't know what it is, it's wide and it's tachycardic, you don't know what it is, amiodarone or procainamide. Unless the patient has a history of heart failure, then you can't get procainamide because it decreases myocardial contractility. It's either amiodarone and lidocaine. But of course, what you always do is in the hospital give amiodarone, everybody's on it. Very important, verapamil and adenosine are contraindicated for the treatment of wide complex tachycardia. You don't give verapamil or adenosine when you have wide complex tachycardia and you don't know what it is. No patient with wide complex tachycardia should ever receive verapamil. Or for that matter, they shouldn't get any calcium channel blockers, beta blockers, or digoxin. And here we just say it again. Verapamil and adenosine are contraindicated in patients with wide complex tachycardia. Also, what's contraindicated is calcium channel blockers, beta blockers, and digoxin. Now, when you have someone with stable VTAC, you go to cardioversion. And then if you don't want to do cardioversion for whatever reason, if it's monomorphic and having the same configuration, if the cardiac function is not impaired, you go to amiodarone or procainamide. And then if you have cardiac function that's impaired, decreased myocardial contractility, you can't use procainamide, then you can go with lidocaine. So amiodarone, procainamide for good heart, amiodarone, lidocaine for a bad heart. If you have polymorphic VTAC, you have to say it's a QT interval prolonged prior to going into the VTAC. If it wasn't, then one would think about amiodarone. Whereas if the QT interval is prolonged, then you got to think about magnesium and pacing. A 75-year-old patient with a rapid AFib, 160 a minute, irregular palpitations for a week. No evidence of cardiac or circulatory failure. What would be included in the initial orders? So here's somebody in AFib, heart rate 160, and been in for a week, and no evidence of any kind of failure. So just give them oxygen, IV, and a monitor. All right, you continue to care for the same patient, and which of the following would be most appropriate treatment for his AFib? What are they going to do now? He's in AFib. What are they going to do now? And what they're going to do is they're going to give diltiazem to slow down the ventricular response. You see, you don't want to give digoxin because you may convert him. And he's been in AFib for a week, and to convert him after a week will send lots of clots to his head. Amiodarone may convert him too, and you don't want to do that. And synchronize may convert him, and you don't want to do that. So the only thing you could do, since his heart rate is 160, is maybe give him some diltiazem in order to slow down his heart rate. That's it, the calcium channel blocker. For a 25-year-old woman is admitted with PSVT, prior to medical history confirmed reentry tachycardia, no Wolff-Parkinson-White, heart rate 180, she's short of breath, reports palpitations, and what should happen to her? And you would say she should be given adenosine. That's it. 55-year-old male, congestive heart failure, left bundle branch block. He has wide complex tachycardia. Which of the following is the most important initial medication? Wide complex tachycardia, you're not too sure what it is, you're going to give amiodarone. Remember that verapamil is contraindicated. When you talk about unstable tachycardia, no matter what the cause or what kind of tachycardia it is, you got to have suction available, pre-medicate, and the answer is synchronized cardioversion. Cardioversion must be done to people with unstable tachycardia, no ifs, ands, or buts. Oh, look, Nurse Week. Look at the little trinkets. See, little trinkets you get for Nurse Week? My hospital, we got green lollipops. Said on the wrapper, you are our lifesavers. They wanted to have printed, you are our suckers. No, I'm sure that's what they want to have printed. But this is how it should be, Nurse Week. Right? Mink coats, doctor, rolling out rug carpet, Nurse View Hospital Center, valet park, and nurses only. Rose voice, okay? Hello. All right, we're going to eat lunch, and we'll see you back at 1:15. Those of you that want the any Ccrn video or Ccrn audio tapes, and you want them at the reduced price, come see me now, because when you come back from lunch, we won't be taking any more orders. So if you're interested, come see me. Back to work. Now what we'll do is we'll do some questions. Watch how smart you are. Here we go. Which of the following pressures are within normal limits? Which of the following pressures are within normal limits? And you would say D. Very good. And you notice the wedge is less than the PAD. Because if you had a condition whereby, let's say the wedge was 16 and this was 12, your wedge can never be higher than your PAD. If it is, it means that the catheter is in zone 1 or 2 as opposed to being in zone 3. Which of the following would cause an elevated pulmonary artery pressure and a normal wedge pressure? Which one of these give you a normal wedge but a high PAP? And you would say pulmonary hypertension. When people have pulmonary hypertension, the PAP is elevated, but the wedge is normal because the wedge tells you about the left side of the heart. Good. A large V wave. A large V wave appears on the pulmonary capillary wedge pressure tracing of a patient with an inferior wall MI. This finding is consistent with mitral regurgitation. Because whenever you have mitral regurgitation or mitral insufficiency, your mitral valve doesn't close well or good. And if your mitral valve don't close good, the blood during ventricular systole, the blood in the left ventricle, will go up through the incompletely closed mitral valve into the left atrium. With this blood going into the left atrium, with every ventricular systole, the tip of the catheter sees that. So the tip of the catheter is hanging out in the pulmonary artery, and when you have the catheter sitting in the pulmonary artery and the balloon inflated, that tip of the catheter is not only looking at the lungs, but pretty much checking out the left side of the heart. And what happens is it sees the mitral valve open, and it sees the blood being dumped from the left atrium down to the left ventricle. Then it sees the mitral valve close, and then it's not supposed to see too much of anything. But all of a sudden, when your ventricles are in systole, all this blood backs up from the left ventricle into the left atrium into your face. So you wind up getting a pulmonary artery wedge pressure that'll be looking like this, right? It looks like this. And you get what's called giant V waves. And when you take a wedge reading, again, you would not do a mean of the waveform, but you would just find the A wave and do the mean of the A wave in order to get an accurate wedge reading. But when people have mitral regurgitation or mitral insufficiency, you're going to get a giant V wave. And that's when nurses say, the swan won't wedge, the swan won't wedge. ST elevations and absence of R waves in V1 through V4 would be indicative of, and you would say, an anterior septal wall infarction. When you lose your R wave, you lost your anterior septal wall because you got that R wave in V1, V2, V3, V4 because the impulses are going across the anterior septal wall towards the positive sticky. So if you have an EKG whereby in V1, V2, V3, V4 you don't have an R wave, no anterior septal wall. Where is it? Dead. Your patient? Infarcting. Which of the following hemodynamic parameters would indicate left ventricular failure? So you're looking for a high wedge in a patient with COPD. So then you're also looking for a high pulmonary artery pressure as well as a high CVP. So the best answer is D. It can't be C, because to someone with COPD, your pulmonary artery pressure would be high. So this definitely cannot be the right answer. It can't be B, even though this is high, which indicates COPD. The wedge of 16 indicates left ventricular failure a little bit. You have a normal CVP, of which you do not see in people with COPD. People with COPD have high pressures on the right side of the heart. Because of the pulmonary vasoconstriction, because of COPD, the right side of the heart has a hard time squeezing the blood into the left ventricle, into the lungs, thereby it gets enlarged the right side of the heart and you have a somewhat of right ventricular failure. So it can't be that. And then it can't be this either. So the only one that could be right is this one. The reciprocal changes that occur with an inferior wall MI are seen ST depression in what leads. So when you have an inferior wall MI, you get ST elevations in 2, 3, and AVF, but you get reciprocal changes, ST depressions in 1 and AVL. Good. Which of the following complications is most likely to occur in an acute inferior wall MI? People with an inferior wall MI will get a Mobitz 1. That's where you have a constant prolongation of the PR interval, and then you have a P with no QRS. Whereas a Mobitz 2 occurs with people with an anterior wall MI. You know, if you have an anterior wall MI and you develop a Mobitz 2, it's a 94% mortality rate. You don't worry, though, about a Mobitz 1. Mobitz 2, you worry. Mobitz 2, that's involving, what's that involving? I don't know, it's serious, all right? So, I forget. But a Mobitz 1 you don't worry about. You don't worry about a Mobitz 1. But you do worry about a Mobitz 2. People with inferior wall MI tend to develop a Mobitz 1, and you don't worry about it. People with an inferior wall MI develop AV dissociation. You worry about that. You make sure to put a pacemaker in. People with inferior wall MIs, as we have said, are usually bradycardic, and you usually don't worry about that unless they become symptomatic. When people are bradycardic with an inferior wall MI, you know, you leave them be. The only time you should give atropine is only if there's a drop in the blood pressure. Then you give atropine. If someone is lightheaded and dizzy, but their blood pressure is okay, then you would lie them flat and just raise their legs. Good. PAT, right bundle cardiogenic shock, you usually see this with anterior wall MIs. Your patient with an inferior wall MI also has a right ventricular infarct. And you would know that because whenever you do an EKG, you do V1, V2, V3, V4, V5, V6. You do it on the left side. Well, you also do V1 through V6, do it on the right side. And when you do V1 through V6 on the right side, your patient who has a right ventricular infarct will give you ST elevation. So you will see in V1, V2, V3, V4 on the right side of the chest, what you're going to see is a configuration that looks like this. You get ST elevation. In V1, V2, V3, V4 on the right side, ST elevation means a right ventricular infarct. So that should your patient have an inferior wall MI and develops a right ventricular infarct, 10% of those people develop right ventricular failure, which he did. Which data obtained would correlate with the patient's condition? Well, if you went into right ventricular failure, you have to have a high CVP. So it definitely can't be B. So it's either A, C, or D. And then if you're right-sided heart problems, your pulmonary artery pressure should be absolutely normal. So that it can't be C, and it can't be D. So it has to be A. So A is the correct answer. So you have a pulmonary artery pressure, 28/10, wedge of 10, the CVP of 18. The treatment modality for a patient with right ventricular failure from an inferior wall MI, this is one that has a right ventricular infarct and went into right ventricular failure, the treatment would be what? And you would say normal saline. When people go into cardiogenic shock or severe failure from left-sided heart failure or an anterior wall MI, the treatment is preload afterload reduction. When you have somebody who has severe right-sided failure or even cardiogenic shock from right-sided failure, the treatment is fluids. The reason why you want to flood the patient with fluids is you want to increase the preload. You want to increase the stretch on the myocardial tissue at the end of diastole. You want to give a lot of fluids because you want to overstretch the right ventricle because you want to stretch heart muscle that never really overstretched before, so that when you're in systole, you could be guaranteed to get blood over to the left side of the heart. Now you might say, well, this person with an inferior wall MI that has a right ventricular infarct, he's got some dead tissue. Yeah, but he got a whole bunch of good tissue. And by giving lots of fluid and over distending the good tissue, I can be guaranteed that when you're in systole, you're sending blood over to the left side of the heart. So when people have right ventricular infarct from an inferior wall MI and go into right ventricular failure, the treatment is lots of normal saline. Which of the following groups of hemodynamic data reflects cardiogenic shock as opposed to hypovolemic shock? So which one of these is cardiogenic shock? Well, it definitely can't be A, because cardiogenic shock, you wouldn't have a wedge of 12, which is normal. So it's got to be B, C, or D. And if you're in cardiogenic shock, you're going to have a high pulmonary artery pressure, a high PAP, because cardiogenic shock comes along with a pulmonary edema. So it can't be C, where you have a normal pulmonary artery pressure. So it's either B or D. Now it can't be B because your wedge is higher than your PAD. So it's got to be D. You might say to me, 94 with 56, that's not too shocky. Well, it depends. If he was a guy running around with a blood pressure of 180 over, 110, he's in shock. Clinical manifestations of cardiogenic shock following an anterior wall MI include all the following except. So all these clinical manifestations of cardiogenic shock, well, definitely going to get distended neck veins, definitely going to get pulmonary congestion and rails, definitely going to get an S3. You're not going to get a low CVP. If anything, you will eventually develop a high CVP as the pulmonary edema and all the pressure backs up into the right side of the heart. Unloading therapy by giving nitroprusside is beneficial because it enhances ventricular emptying, diminishes peripheral vascular resistance or afterload, relieves pulmonary congestion by promoting venous pooling of blood, and the answer is all the above. Which of the following is an expected outcome from the intra-aortic balloon pump? Well, the best answer here is improving your cardiac output. You definitely don't want to increase anybody's wedge, and you don't want to decrease the BP, so the answer is an increased cardiac output. To be operating correctly, the intra-aortic balloon pump is timed to work in which of the following manners? And you would say the balloon will inflate during diastole, deflate during systole. So the balloon will inflate when the heart's inflating, the balloon will deflate when the heart's deflating. And the contraindication to intra-aortic balloon pump is aortic insufficiency. And if you were to read in somebody's chart that they have aortic insufficiency, what kind of murmur is that? And you would say aortic insufficiency is a murmur that is made whenever the aortic valve is supposed to be closed. When's that aortic valve supposed to be closed? During? When's the aortic valve supposed to be closed? During? Diastole. Therefore, aortic insufficiency is a diastolic murmur. You're going to go into the patient's room, and what are you going to be singing? Lub dub murmur, lub dub murmur, lub dub murmur. The murmur of aortic insufficiency is blowing. So what you hear is lub dub, lub dub, lub dub. Very good. You'll be a hit when you go back to work. People want to touch you. The guys are saying, I can get into that. Absolute contraindications to the intra-aortic balloon pump include aortic insufficiency. Very good. Hey, anyone thinking about being a nurse anesthetist? You know what they're paying now? I know at Staten Hospital, they're starting nurse anesthetists at $170,000 a year. Isn't that something? You got nothing to do with 2 years of your life? Go to nurse anesthetist school. It's not bad. $170,000? And if you have your Ccrn, because they really want you to have a Ccrn before they admit you to nurse anesthetist school, that's something to think about. It's a 2-year program. You could do it. You went to nursing school, you could do nurse anesthetist school. It's a piece of cake. Really, not bad. I don't know, do any programs around here? Columbia have a program? Downstate has a nurse anesthetist? How long is their program?
Their program is a year.
A year?
You don't have your bachelor's, it's 1 year, 1 day a week.
1 year?
I'm entering next year.
So it's 1 day a week for a year?
For your bachelor's,
Uh-huh.
it's 1 day a week, Wednesday. It's all day, but so I blow a day all day. It's 1 day a week for a year for
One-
your bachelor's,
Uh-huh.
and then their anesthesia program is 1 day a week, but they really don't want you to work. It's very concentrated, but
Oh, you could work. You're a nurse. That's not bad. Right? That's something to think about. Here, you're busting your hump for a stupid Ccrn that you'll get paid 10, 15 cents an hour, right? All right, enough ideas here. All post-operative cardiac surgery patients develop. Look, everyone's going to leave critical care and go into the OR now. Hey, go with the money. You know what I'm saying? Life is too short. Do things for your personal satisfaction when you retire. All post-operative cardiac surgery patients develop. They all get pericarditis. Only 88% of them get atelectic tissue, but everyone gets pericarditis because they cut the sac. Which of the following kinds of shock is characterized by increased venous capitance and pooling? You know, in your core curriculum, they refer to as septic shock as distributive shock. So in your core curriculum, distributive shock is the same thing as septic shock, and you know that it's the release of the endotoxin that causes massive vasodilation that gives you the pooling of your blood. 50% worth of your blood is pooled. Early stages of septic shock are characterized by, let's see, you don't have any vasoconstriction. You get increased cardiac output, but you don't get vasoconstriction. Increase, the answer is, early stages of septic shock are characterized by increased cardiac output with decreased vascular resistance. And that decrease in vascular resistance is due to vasodilation because of the endotoxin. The signs of hyperventilation, diminished sensorium, and an increase in cardiac output are found in which form of shock? And you would say septic. So hyperventilation, diminished sensorium, increased cardiac output are found in septic shock. So look, crazy, increase in respiratory rate, increase in cardiac output, and lots of urine, right? So boop, 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 boop is septic shock. Whereas what's this? Also carcinoma, viral pneumonia, head problem. Good. Also carcinoma, viral pneumonia, head problem, as opposed to, you know, do. That's it. A patient admitted to the ICU in the early stages of septic shock will present with what? Early stages, yes, you get warm, flushed skin because your pulse is bounding. Your urinary output is increased. You do get hypopenia, I don't know how to say that word. Hypopenia. It's like cinnamon, you know? Sometimes I can say something, hypopenia or something like that. Sounds like a male disease. Hey, I'm not coming in today. I have hyperpenia. Anyway, hypopnea. But you don't get pulmonary congestion. So the answer is warm, flushed skin. Listen, when you have to call in sick, make sure you use a nursing diagnosis. Because in my hospital, whenever you call in sick, you always got to speak directly to a supervisor because then they think that you'll be too afraid to call in sick. And then whenever you get them on the phone, they always want to know what's the problem? Like they're really concerned about you. So anyway, they're like, well, what's the problem? I said, you know, I'm having an alteration in oxygenation related to increased mucus production. They're like, no, what's really the matter? I said, you heard me, I'm having an alteration in oxygenation related to increased mucus production. She's like, no, what's really the matter? I'm like, you're not asking me to make a medical diagnosis, are you? Because I'm going to have a potential in violence, because that's on that list too. Which of the following, isn't it sad how so many years of schooling was wasted on the nursing diagnosis, you know? Rather than nursing theory and all this other crap. And I'm a PhD person. I got a PhD in nursing. Really, I'm going to be shot for saying this, but it's such a bunch of garbage. I mean, really what they should be teaching you after you get your RN and you go on for your bachelor's and your master's and your doctorate, they really should show you how marketable nursing service is. I don't understand why nurses don't form corporations. I don't understand why all the nurses of the open heart unit don't form a corporation and market that service of open heart nursing back to the hospital. Why don't all the nurses of the ER form a corporation and market that service of emergency nursing back to the hospital? Why don't all the nurses of the surgical ICU form a corporation and market that service of surgical ICU nursing back to the hospital? Control your own ship. Be your own boss. Go in for a salary. You have to keep your mouth shut to get a lousy paycheck. God forbid you open your mouth, get labeled as having a bad attitude and all this other garbage. Who needs this crap? Everything to hold you down. So they teach all this nursing diagnosis, all this verbal babble invented by people that don't practice. They teach all this ridiculous nursing theory, all this other foolishness, and they use up all your time teaching all this stupid stuff, when really they should teach you how to form corporations, form your own business, and kick a little butt. Next topic. All right, but which of the following signs is not a characteristic of cardiac tamponade? So which is not a characteristic of cardiac tamponade? You definitely get a rising CVP, you definitely get a wide mediastinum, and you definitely get pulsus paradoxus. You don't get a widening pulse pressure. When you have cardiac tamponade, you get a narrowing pulse pressure. The people that are going to give you widening pulse pressures are people that hit their head. You hit your head, you get a widening pulse pressure. Hit your chest, you get a narrowing pulse pressure. If you work in the emergency room, sometimes you're in a jam because when someone comes in, multiple trauma, car accident, chest hits steering wheel, breaks it in half, head goes through windshield, then you're stuck, right? Head, windshield, widening pulse pressure, chest, steering wheel, narrowing pulse pressure. They're like 120/70, just send them home. No. Placement of MCL electrode is where? Where do you put MCL1? That's supposed to be 1. MCL1, the positive electrode is the 4th intercostal space, right sternal border. Positive electrode right over here. The negative electrode is below the outer third of the left clavicle. So MCL1, which is a very good lead to differentiate ectopy from aberrancy, your positive stickies over here, the negative stickies over here, and you put the ground anywhere you want. And this is a very good lead in that you could differentiate ectopy from aberrancy. Because you know when people have an aberrantly conducted beat, it's no big deal. It just means that the beats start in the atrium, and when it came down into your ventricles, one of your bundles is tired. Usually your right bundle gets a little cranky when you get on in years. So when you have an aberrantly conducted beat, it's usually because of a right bundle branch being cranky. And so you get an aberrantly conducted beat that takes on a right bundle branch block look to it. And of course, you can only see this in MCL1 or in V1. You cannot use any other lead. And so when that patient has the aberrantly conducted beat, it'll look like this. Now, ordinarily in V1 or MCL1, you look like this. So you have to be like a real nitwit not to notice this configuration out of this. And then if someone's going to have a PVC from the left ventricle, a PVC from the left ventricle will look like this. So you see the difference? If you have someone in V1 or MCL1, the only leads you should really monitor people in, and you should be seeing this. If you have someone in V1 or MCL1 and you see this, you say, oh, you have big mountain, you have big problem. Big mountain, big problem. Whereas if you have little mountain, you have little mountain, you have little problem. An aberrantly conducted beat, you don't worry about it. Little mountain, little problem. Big mountain, big problem. Be a hit when you go back to work. The most serious EKG finding associated with an anterior wall MI is right bundle branch block and second-degree heart blocks. Very good. The hemodynamic parameter that clinically measures afterload would be SVR. All the following support the diagnosis of cardiac tamponade, except if you have cardiac tamponade, definitely going to get a large heart on X-ray. Definitely going to get pulsus paradoxus. You're going to get equalization of right and left heart pressures. You're not going to get A. You're not going to get a widening pulse pressure. You're going to get a narrowing pulse pressure. Patient comes in with a blood pressure, 200 over 142. What kind of hypertension does he have? Malignant. He has malignant because the diastolic is greater than 140.